Hi everyone, I'm Darlene with QRS Educational Services and welcome to the ECG Assessment Little Micro Learning. I developed the RIRI systematic approach decades ago to help me when I was first working in CCU so I didn't omit anything important. The first R is to calculate the heart rate. You want to look at a 6-second strip of time, and that can be easily identified from looking at the beginning of your 12-lead ECG to the middle of your third column where V1, V2, and V3 line up. The middle of that column is the end of 6 seconds. So pick any row, count the number of QRS complexes in that 6-second strip, multiply by 10, and there you have it. Next is we're going to quickly look at intervals. You don't need to look at every lead. Really, just usually lead 2 should be enough. And we're not taking calipers to measure what the actual number is. We are looking at the intervals to determine, just quick and simple, are they normal or are they abnormal? An abnormal PR interval is likely because of an AV block, and in the setting of an MI, AV blocks often will need to be paced. So you want to find that out right from the beginning. Next interval is the QRS complex. Is it normal or is it wide? Quite often in the setting of an MI, a patient may develop a bundle branch block. And in that situation, the ECG may mask or mimic an MI. So that's something that's really important to determine at the beginning. The last interval is the QT interval, and you're assessing to see whether it is within half of the 2 QRS complexes beside each other. And if it's over half of that distance between those 2 QRS complexes, the patient may be at risk of torsade de pointe, which is a type of cardiac arrest rhythm. Those are your intervals. You want to get them done quickly, then move on. The second R is the rhythm. When we're looking at rhythm, we're looking to identify what the rhythm is, but most importantly, how is the patient? Are they stable or are they unstable with whatever the rhythm is? The final I is going to take most of the time. You need to look at each lead and you're looking to see if the ST and the T waves are at baseline and the T waves are upright. That's normal in every lead. Now, if you're seeing ST segment elevation or ST segment depression or T wave inversion, and your patient is also experiencing some type of cardiac presentation, then they are likely having an acute coronary syndrome. Intervention would need to be done right away in those particular situations. If you want more information on ECG interpretation, I have a couple of different on-demand courses that you may be interested. One for entry level, one for a review. You've got a little bit of knowledge, but it's been a while. That combined rhythm and ECG would be a good course for you. The other course that I also have for more advanced practitioners is the advanced ECG course. I also have pocket cards. If you'd like more information on any of this, please reach out. Thanks.